Afternoon, everyone, and delighted to be speaking today. The order has got a bit switched around, and we had Professor Murray first, which was, I think, a fantastic presentation around, the I guess the science and the beautiful work that he's done to highlight this. I'm going to be first of all, thanks to Professor Basu, and I think the tremendous organization and work for this conference, which I think really sort of represents a landmark for public mental health in India. I'm really delighted to be talking to you, and I'm going to cover a few areas today. So I'm going to give a little bit of an introduction before talking about sort of the opportunities for action, and to go through some of these areas outlined here, and then to really kind of look at and build upon some of the discussion that's happened earlier. So just to remind everyone, I think this is really kind of quite important to just kind of focus in terms of why public mental health approaches are so relevant. So we're looking here at the proportion of disease burden, which has been consistently underestimated, and I've highlighted two examples of years lived with disability and DALYs. And then the reasons for the size of burden, which relate, first of all, to high prevalence of mental health conditions, but also sub-threshold mental health conditions, which had further impact. Secondly, the majority of lifetime mental health conditions arising before adulthood. And thirdly, the broad range of impacts. And I've highlighted a few health-related impacts here, which are not just premature mortality, but high rates of physical health conditions and health risk behaviours, but also across other sectors such as education and employment. And then these huge associated economic costs. So actually, this is also a key economic issue. And I've highlighted the global projection that annual global cost of mental health conditions will exceed $6 trillion by 2030. Mental well-being also has a broad range of impacts, and I think that therefore sort of highlights its relevance as a key asset. In terms of a public health approach, we know that different factors predict mental health conditions and well-being, and as for other disease, we need to be thinking about how we address those. And Robin sort of highlighted cannabis as one, but I think particular relevant risk factors for mental health conditions are important during pregnancy, early years, given the majority of lifetime mental health conditions arising before adulthood. Child adversity, I think, has been mentioned several times, but represents a very large proportion of a cause of a large proportion of mental health conditions. And also child mental health conditions then result in a 2 to 3-fold increased risk of mental health conditions during adulthood. So they themselves are also risk factors. And risk factors also increase the relapse of people in people with mental health conditions. So as psychiatrists, actually, it's not only relevant for primary prevention, but also for relapse. So we need to be thinking about these risk factors within our own patients. Some risk factors are more important because they have overarching impacts on others. And I give a few examples here: socioeconomic inequalities, the pandemic, climate change. And furthermore, as was highlighted yesterday, some groups have several-fold increased risk of mental health conditions. Examples were given as for intellectual disability, but also if you think about refugees and migrants, LGBTQ, and other groups. And this is due to a clustering of risk factors in those groups. And that's essentially mediated by social disadvantage. And therefore, we need to be thinking about how we target those groups more effectively. In terms of interventions, we're very fortunate. As I mentioned yesterday, we have evidence-based intervention, very good evidence for a range of interventions, not just to treat, but to prevent associated impacts, prevent mental health conditions, and to promote mental well-being and resilience. So the evidence is there. We can also think about these interventions at primary, secondary, and tertiary levels of prevention and promotion. And importantly, as for other mental health conditions, as for other health conditions such as cardiovascular disease, we need to be thinking about this balance between different levels to sustainably reduce the disease burden from mental health conditions and promote population mental well-being. We need to be thinking also about how we target these groups at several-fold increased risk at each level of prevention in order to prevent widening inequalities. Now, one of the challenges is the broad range of stakeholders and providers. And you can see here, I've made a list of different types of providers. And if we're thinking about how we deliver at population level, we need to be actually engaging with these different sectors. I know highlighted, for instance, traditional and faith healers. Those are recognized as a potential key asset, particularly where we don't have a large number of psychiatrists. I've got a slide on economics here. We know that effective interventions exist and they're the right thing to do ethically. However, many evidence-based public mental health interventions also have cost-benefit evaluation, highlighting economic savings even in the short term, and overall savings are related to the level of population coverage. And there's an economic cost of not providing interventions. And so appropriate coverage of public mental health interventions is also a key part of sustainable economic development. So we're again widening actually the relevance, the audience for this approach. However, we know that for any intervention, the population impact is dependent on its coverage and outcomes. But despite the fact that we have these evidence-based interventions, globally only a minority of people with a mental health condition receive any treatment. And that's even in high-income countries such as UK, with far lower coverage of treatment in low-middle-income countries. There's far less coverage of interventions to prevent associated impacts, and virtually no implementation of evidence-based interventions to either prevent mental health conditions or promote mental well-being and resilience. And this implementation gap has widened further since the pandemic. And the impacts of the gap, well, population scale, preventable human suffering, broad impacts, lost potential, economic costs. We look at just one family and we look at the impacts of, for instance, that lost opportunity. It really focuses the mind, but we multiply that by 1 million, by 10 million. We can see that, this is catastrophic. This breaches the right to health and also to ethics, which we've been talking about, and also it contributes to lack of preparedness for public health emergencies. And the causes, well, they're important because that actually informs some of the solutions. First of all, there's insufficient public mental health knowledge, and that relates to insufficient training for professionals, trainees, not only in psychiatry, but primary care, public health, policy. There's insufficient understanding about size, impact, and cost of the implementation gap. And there's also insufficient understanding about what are the benefits and economic savings of improved coverage. And the second relates to policy. So we've got insufficient use, first of all, of evidence in policy. We've got insufficient transparency about policy decisions about acceptable population coverage of interventions and mental health policy implementation according to need. There's insufficient resource, and I think that's been highlighted by Devora earlier. 2% globally of health expenditures allocated to mental health. And that's despite the figures I highlighted in my first slide. And there's far less in low middle income countries and negligible public health expenditure on public mental health. There's also a political call, so insufficient political will, and also the political nature of some interventions and activities, for instance, addressing socioeconomic inequalities. Stigma underlies many of these risk factors, and so there's an overarching barrier in terms of the causes, but also for the treatment gap, there's insufficient workforce and skills, insufficient treatment quality, insufficient demand in part mediated by stigma, but also very high levels of burnout amongst the staff. We talked about defining public mental health yesterday, and it was something that the WPA's Public Mental Health Working Group really kind of thought a lot about, and I really wanted to pay tribute also to Afzal Javed, who, as president of WPA, has made public mental health a key part of the current action plan for the WPA. But again, Afzal and others contributed to actually thinking about what the key elements were of public health, which include a population approach to improve the coverage, outcomes and coordination of public mental health interventions. And as I mentioned yesterday, that leads to efficient, equitable and sustainable reduction in mental health conditions and promotion of mental well-being across populations. And that's quite helpful because then it gives us a clear idea of what should we be thinking about. Now, in terms of drivers and values to support public mental health implementation, I've got values in there, and I think we talked quite a bit about values yesterday. Norman was referring to it. And I think values really underpin so much of a population approach to mental health, where we're thinking about what should we be doing to address this huge unmet need, which I mentioned, and that the impacts that has. Drives include the UN Sustainable Goals. We heard about those earlier, but they commit to treatment and prevention of non-communicable disease, including mental health conditions, and a target of universal health coverage, which includes mental health. And I think that really kind of is a key important thing to note. There's the right to health, the UN declarations. Norman also, in his article in the current issue of World Social Psychiatry, talks about mental health being dependent on the protection of human rights. Leadership by various organizations, so WHO, World Psychiatric Association, the Royal College of Psychiatrists, for instance, recently launched a public mental health implementation center. We've got the World Federation of Public Health Associations really buying into this area. And I think also COVID led to an increased interest in mental health and implementation, addressing the implementation gap for both populations and government. And then to this kind of last section, which is the opportunities for action. I think these are really important to be thinking about in a real kind of translatable way. I think, as speakers have highlighted earlier, there are lots of policies, and I was myself involved in writing policy for the Department of Health in the UK. But when I wrote it, I hadn't realised the lack of implementation plan for the policy, which was kind of a real lesson for me. But I think there are opportunities here in these 7 areas for us to be thinking about translatable actions. So I think the first translatable opportunity is to be thinking about the assessment of public mental health need, which varies by country and locality. And we assess the size of the gap, but also the assets. What's there already which we could build on? And that's at both national and regional levels. And we need to be thinking not just what's been done by psychiatrists, but by a broad range of sectors. We identify the causes of the gap, because they will vary by locality and country. And then we estimate the impact and associated economic benefits of improved coverage by different sectors. And a key collaborative partner is public health with all of this. So I think we need to be thinking, who is our public health partner in, for instance, Chandigarh? And I'm sure you know, because obviously you're a public mental health orientated centre here. And the next part is about the public mental health practice. So we use the need assessment to inform policy and strategy, including not just across health, but different sectors. We use it to inform the choice of effective and implementable public mental health interventions by different sectors. We think about ways to scale up implementation. And again, that will vary depending on the region, the country. And then we think transparent, we then come to transparent decisions about what is an acceptable level of step provision and required resource. I use step provision to think about where are we now and where do we want to get to, for instance, by 2030. For instance, what is an acceptable level of child abuse to be left unmet? And I think this, I'll come to this in the next slide, but then we communicate these decisions to different agencies and wider populations. We plan commissioning, operationalization, and interagency coordination. And then we implement according to the population level that we've agreed for this year, but maybe that will be increased by 2025, 2027, and then by 2030. So we're thinking about very tangible goals for population coverage. And then we evaluate the population coverage and outcomes of the intervention, but also this really supports accountable transparency. And for that, we require a system for appropriate data collection. And again, we're thinking about our public health colleagues here around the broader population approach. The third opportunity is around coordinated advocacy, leadership, and making the case. WHO, in its mental health atlas, which I'm sure you're all aware of, but it's a very interesting publication. I'd recommend reading. The last one was published in 2021, but it recommended that global targets can be reached by 2030 only if there's collective global commitment over the next 10 years across member states to make massive investments and expanded efforts at country level relating to mental health policies, laws, programs, and services. And this requires coordinated advocacy and leadership by a range of stakeholders. The stakeholders, this range, need to transparently agree what is acceptable population coverage and required resource, taking account of several issues. First of all, the population scale preventable human suffering, broad impacts, loss potential, economic costs from the current gap. And that links to ethical principles. Then, what are the impacts and associated economic benefits of improved coverage? Then the right to health, which we've talked about extensively over the last 2 days. But it's not just the right to treatment, it's the right to prevention, the right to promotion. The UN SDG of universal health coverage. And then we need to be thinking about the stakeholders, and these include people with lived experience, carers, community health providers, voluntary sectors and NGOs, education, employment, social care and services, criminal justice, policymakers, ministries of health and ministries of finance. And I think this is a key bullet here, because I think this is really of the people, by the people, for the people. And I think to give an example of the opportunities here, and often people start getting their phones out whenever I show this slide, is the economic impact. Because this, although it might be slightly reductionist, and some people will say, well, actually, no, implementation is the right thing to do anyway, this is a form of advocacy and persuasion. So I did a piece of work which looked at what would be the total net savings if 9 public mental health interventions mentioned in a previous England mental health strategy were implemented to the required scale across England. And the net savings were almost 44 billion UK pounds over different timeframes. And they include school-based social emotional learning programs, the savings from school-based bullying prevention programs, workplace screening and early treatment of depression and anxiety, primary care-based screening and brief interventions for alcohol, workplace, that simple set of interventions to promote well-being and resilience, well-being for all employees. Now, you can immediately see, look at this. I mean, this is kind of relevant to everyone, isn't it? And particularly to the relevant sectors. And a colleague of mine from WHO also estimated these economic savings from scaling up the treatment of anxiety and depression. This was across 36 countries between 2016 and 30. So this is these are important elements of advocacy. They're not actually, obviously they're just part of advocational opportunities. Then, of course, there's training and population knowledge. So public mental health training is required to reflect the global disease burden due to mental health conditions. And training really is both broad and specific to specific public mental health delivery. So some sectors will be delivering particular types of interventions, while other sectors will be delivering others. So we need to be thinking both across the broad principles, but also be quite specific about delivery. And I've put there, in terms of national and local policy makers, they're key for training as well, because often they have no training in either mental health or population health. And also people with lived experience as representatives, as the key participants in the making of strategy are also important. And improved population knowledge about mental health is obviously relevant to us all, every one of us. because actually it's every family in the land is affected, either directly or indirectly. The role of the media is important, but when we think about ourselves, we have much higher rates of mental health conditions compared to the general population. We've had higher rates of burnout, and we look at medical students. I mentioned yesterday, a recent review highlighted almost half of medical students at the end of their training were burnt out. So this has direct relevance to all of us, as well as what we do in our jobs. Particular opportunities, well, setting-based approaches, so they enhance the coverage of more than one intervention. And we can think about various settings. I've highlighted various here, but yesterday there was a question about what were the top interventions, for instance, for schools. And they represent, I think, these earlier year targeting children, young people are particularly important. Integrated approaches, we know mental health conditions and well-being result in broad impacts across sectors. Public mental health interventions are delivered by a range of organisations from different sectors. So we need to be thinking about how we integrate mental health within the work, into the work of both within sectors, but also between sectors. And this is supported by integrated working between different sectors, locally, nationally, and internationally. Do we know who are the key leads in these sectors, for instance, in Chandigarh or wherever we work? But also it's supported by mental health needs assessments, which kind of map out who's doing what, where. And then digital technology, of course, that's been mentioned again several times, supports delivery of many interventions, but also supports delivery of training to scale. Maximizing existing resources through various ways, so self-management, including self-help, use of digital-based interventions, I think a great opportunity. And I think this appreciation of what could be achieved through this is being realized more and more every day. Use of culturally embedded interventions, we think of yoga, meditation, for instance, maximizing treatment resource through collaborative care, task sharing, improving quality of and in concordance with treatment. And obviously WHO for a long time has been recommending this movement of expenditure from large hospitals to more community type services. And then particular interventions, I'm highlighting actions to address socioeconomic inequalities, which underlie many other risk factors for mental health conditions. When we think about our patients, they're disproportionately affected because they're unemployed, they can't work, they've lost their income. So how do we address that risk factor as part of recovery as well? Action to address stigma and discrimination, which again underlie so many other issues are highlighted. Parenting interventions, which not only promote parental mental health, prevent child mental health conditions, but also represent first-line interventions for several mental health conditions among children and young people. Addressing parental mental health conditions. In the UK, 1 in 4 parents are affected by a mental health condition, which results in tripling the risk of mental health condition in their children. Addressing child adversity, which I've mentioned already, and increasing physical activity, which improves mental health across the life course. Then the use of legislation and a rights approach. So legislation is there often in countries. And we think about workplace safety, equality, stigma and discrimination, protection of children and families from adversity and violence, but it's not implemented. So there's an opportunity to be thinking with legislators, how do we implement this intervention appropriately? The right to health, the right to mental health and evidence-based public mental health interventions, particularly for these higher risk groups. The right to quality care, and the rights approach really being an important mechanism to advocate for appropriate coverage. But also we need this, as I mentioned earlier, we need a way of actually monitoring how well are we doing, and we need appropriate data to monitor coverage and to make sure that we're heading in the right direction and achieving our goal of universal health coverage. And then finally, implementation research. We've got all these amazing meta-analyses, systematic reviews of what we know work, but it's not being implemented. So we need some kind of focus on the research of how we implement to scale in localities. And then we can even do that research at a local level, such as in Chandigarh. So in terms of summarizing, mental health conditions and poor mental well-being have broad impacts across sectors which have been exacerbated by the pandemic. We have effective public mental health interventions, but implementation failure of these interventions result in this population scale, preventable suffering, broad impacts, and associated economic costs. This represents a breach of the right to health and being further amplified by the pandemic. We know that implementation can be improved in several ways, and this improved implementation results in broad impacts across sectors and achievement of a range of policy objectives. It results in economic benefits in the short term and as such is an important part of sustainable economic development. It supports the achievement of the UN SDG target of universal health coverage and therefore makes public mental health a key opportunity for collaboration and integrated working. Thank you for your attention. And just to give you finally just a few references there, including some of the WHO relevant publications. Thanks a lot.
Thank you very much, Jonathan. I think this says time's up, but I'll give people a choice. Those who have would like to have food for their appetite, they can carry on. Those who would like food for thought can stay back. This is a buffer time. I hope, Devashish, it's all right. There is no hurry for lunch. So would you like to take some questions from here or from there? Okay, I have the first one. You've talked so much about this. I think people would like to know what is the cost estimate for assessment of public mental health needs or intervention or research. I'm quite sure you have done so much. Give us an idea about that.
So the cost need for assessment and implementation.
In interventions.
Yeah, so I think in terms of the assessment, now I think this should be part of, psychiatrists' work to work with our public health colleagues in a joint way. So, for instance, in London, in the UK, I work with my public health colleagues, and we work to, for instance, I help them with estimations of prevalence and then numbers affected by mental health conditions. We then work out how many are getting treatment. And then we look at numbers of risk factors, number affected by risk factors, how many are getting interventions. So that's an exercise that is shared in terms of cost between public health and secondary mental health care as an example. Now, in terms of cost of implementation, this is obviously something which is, when we've got restricted budgets, this can be challenging. But I think the key part of this is what I highlighted in that slide in terms of net returns on investment, because everyone's interested, I think, in this area. So for me, I did a piece of work, for instance, in a region. I estimated, for instance, the impact of conduct disorder on criminal justice related issues, the numbers affected and the net savings that would accrue through parenting interventions for children and young people with conduct disorder. Now, parenting interventions are provided sometimes by child and adolescent mental health services, sometimes by third sector organisations. But what happened was when the police commissioner for the region saw the savings, he said, I will use my police budget to pay for all these parenting interventions for 5,000 children, because I can see that 70% of the savings will accrue to my police budget. So that's just an example of, I'm not giving you exact figures, but an example of the opportunities, I think, for cross-sector working, because sometimes the benefits of an area for prevention might accrue to another sector. So the sector who's paying for it sometimes can be a little bit, how can I say, a little bit hesitant. So.
Thank you.